Consent. Awesome. So, welcome to Geisinger's Bold ERG. We are in partnership with BSP CAC and the NAACP Wilkes-Barre chapter for Black Men's Health Matters. So again, this is by the Bold ERG. We want to thank our subcommittee for helping coming up with this and being such a huge part and a definitive player. Ms. Priscilla Cabral, Faith Bansal, Tamara Dickey, and Dr. Vicky Sapp. So my name is Dr. McBride. I'm an infectious disease doctor here. And in addition to that, I'm also the co-chair of BOLD with the illustrious Dr. Vicky Sapp. And I'll be your moderator. So I was a little sick. You're getting my Dr. McBride after hours voice. Okay, thank you. We would like to thank Mr. Breeze, Brian Lieberman, Ms. Michelle Ansel for your support for and BOLD as advisor, a sponsor, and administrator. We would like to thank the marketing department, Ms. Heather Davis, Liz Zygmunt, and Elise. Annalise. So we've had a bunch of different series this month. Thank you so much if you could join us. We really appreciate it. Today is the June 22nd, noon to 1:15. We'll be discussing racial and ethnic disparities in child and adolescent healthcare. On June 29th, we have another session with Dr. Wilkins on cancer in Black men, the disparities in the science associated with that. And we also have Tuesday night community chats with our journal club, and we'll be discussing the Netflix series Amend. We have one this evening from 5 to 6 p.m. So please come if you can. It's on episode 4, Control. All right. So again, just a little bit about the Black Outreach and Leadership Development, ERG. We embrace culture and inclusion. We try to build awareness and appreciation of diversity. And we cover everyone in the Black diaspora, from Black, African-American, Afro-Caribbean, Afro-Latinx, et cetera, trying to build a community here at Geisinger. And we welcome all for your interest. If you want to be a part of it, just email anyone in the next slide on BOLD. So you can hit Mr. Lieberman up, either me or Dr. Vicky Sapp, and Arthur Breeze, if you'd like to be a part of it. We also have other ERGs here: Women League, G Pride, VetNet, and GAIN. All of those you can be a part of as a Geisinger employee. All you have to do is reach out to the folks listed here. We're also having a mug giveaway here. So please sign up for this if you can. The first 5 win one for free. So, and I would like to introduce Mr. Arthur Breeze to give the spotlight of Black excellence. Are you here, Arthur? Hello? I'm not sure if he can hear me or not. In that case, I'll do it. Hello?
Dr. McBride?
Yes, sir.
Okay, I apologize. I'm on my iPad, so I couldn't take off the mute button. Thank you very much.
Absolutely. So I'll just go on to the next slide then.
So 2021, the Black Excellence in Medicine Untold Stories. This is created by BOLD ERG Education Subcommittee, Health Matters Planning Committee, Mrs. Priscilla Cabral, and then Mrs. Tamara Dickey, and Dr. Vicky T. Sapp, and then Mrs. Faith Bansa. Can you go back to that? Is this? Yeah. So Reed V. Tuckson. Dr. Tuckson has been in the health profession for more than 30 years and has been involved in nearly every part of the sector. He is currently the managing director of Tuckson's Health Connections, a health and consulting business. He was able to serve his community in many capacities and roles, such as the EVP and the Chief Medical Affairs Officer.
So, Arthur, just to let you know, these are the people who have been spotlighted before.
Okay,
Just going to do like sort of a brief one here, and then I'll go to the one that we'll highlight today, if that's okay. So this,
absolutely.
yeah, so this is Dr. Tuckson, Dr. Vicker, Dr. Mighty, we did him on June 4th, Dr. Carlisle on June 8th, Dr. Thomas on the 15th, and we'll get to Dr. Moore, and we're highlighting this gentleman on the 22nd today, okay?
Great, thank you. So Dr. Moore is a certified physician in internal medicine as well as the cardiovascular disease. During his studies, Dr. Moore served as the chief medical resident while he completed his internal medicine residency at Baylor. He also completed dual fellowships in cardiovascular disease and electrophysiology. He currently practices at Methodist Health System in Texas. Thank you, Doctor.
No, thank you so much. I would like to introduce Mr. Morris Jackson. He is going to announce and introduce our speaker for today. Thank you so much for your time, Mr. Morris Jackson.
Thank you for that. Yeah, so as you mentioned, my name is Morris Jackson. I'm a member of the Community Coordination Committee for the NAACP Wilkes-Barre Chapter 2306. And as Dr. McBride mentioned, I'm honored today to introduce today's speaker, Dr. Nicholas Howard. He's going to be speaking today on racial and ethnic disparities related to child and adolescent healthcare. But before he gets to that, just a brief introduction on Dr. Howard. His journey to medicine started in Brooklyn, New York, where he was raised in a Guyanese household with his grandmother, who had many health concerns. She looked after him and many others, which greatly influenced his decision to pursue a career dedicated to the service of children. He received his Bachelor of Science in Health and Wellness from Buffalo State College, as well as his Master's in Public Health Administration from the University at Buffalo, before finishing medical school at Xavier University School of Medicine. He returned to Buffalo to complete his residency in pediatrics at the Women's and Children's Hospital of Buffalo, which is where he developed a passion for initiatives based in global health and providing care to underserved populations. This ultimately led him to Philadelphia, PA, where he is the general pediatrician and attending physician at Tri-County Pediatric and Abington Memorial Hospital, respectively. Thank you very much, Dr. Howard, for being here today. We appreciate you taking the time speaking with us today, and I'm very excited for your presentation.
All right, I will stop sharing my slides here, and I will let you take over, Dr. Howard. Thank you so much.
Okay, thank you guys. How's everybody doing today?
Very good.
Good.
Great.
So let's get started. It's it's a big topic, especially over the last year, but for a lot of us, it's been longer than that, right? So and as medical professionals, it's something that I feel like we definitely need to address. We've had to address it, but I think it's time that everyone address it, and not just those of us that look like us. Yeah. So let's get started. Share my screen. Okay, everybody see that okay?
Yeah.
Okay, great. Okay, so today, let me minimize this. Today, we're going to talk about racial and ethnic disparities in child and adolescent healthcare. We're going to focus more on the racial aspect, but we are going to touch on some of the health disparities as well. Okay, so just a few definitions. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Populations can be defined by factors such as race, ethnicity, gender, education, income, disability, and geographic location. Also sexual orientation. They are inequitable and are directly related to historical and current unequal distribution of social, political, economic, and environmental resources. Okay. Health disparities are also related to inequities in education. All right. We will go into this a little deeper later in the discussion, but not finishing school is associated with multiple social and health problems. Overall, individuals with less education are more likely to experience a number of health risks such as obesity, substance abuse. They're at higher risk for intentional and unintentional injury in comparison with those with higher education, which is most of us, right? Higher education, higher levels of education are associated with longer life and increased likelihood of obtaining or understanding basic health information and services that people need to make appropriate health decisions. Although disparities among children's health and healthcare utilization along demographic lines like race and income, these have all been long documented as factors influencing health outcomes. But more recently, research has been looking more at social determinants of health. These are conditions in the environment where people are born, where they live, where they learn, they work, they play, where they worship and age as we all are. All of these factors affect a wide range of health, functioning, and quality of life outcomes and risks. So if you look at Healthy People 2030, it's a governmental initiative. It's social determinants of health can be grouped into 5 different domains. Economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. We're going to focus more so on the social and community context with our talk today as well. But you can see how racism affects all of these factors individually. Okay, so this is us in the center, right? And this is how these social determinants of health affect our day-to-day living, right? So of course, healthcare, our neighborhood, our social interactions, our economics, our finances, and of course, our education. So discussion of the problem, right? Racism of itself is a system of structuring opportunity and assigning value based on the social interpretation of how a person looks, right? And this is what we as society calls race. This is based on unfair, this causes unfair disadvantages in some individuals and communities, unfairly advantages other individuals and communities, those with more to gain and those in a power structure. And this saps the strength of society as a whole. Racism of itself is a social determinant of health that has profound impact on the health status of children, adolescents, emerging adults, and their families. So in America, racism of itself was transported through European colonization. It started with the subjugation and genocide of the American Indian populations and was encouraged or bolstered by the importation of African slaves. This was the backbone of the American economy. Now, slavery as an institution has been abolished, but there were still all these discriminatory policies and practices, as many of you are aware, such as Jim Crow, which helped legalize the continued subjugation. As the U.S. expanded west and into Alaska, we came across other populations that were also subject to oppression and similarly excluded from society. Pacific Islander, Alaskan Natives, Asian Americans, and Latina Americans. Although some of these groups did receive reparations, when I believe it was in the 1980s, Japanese families of those people who were put into internment camps received about like $20,000 from the U.S. government. So, I mean, to me, it's a small price to pay for the lives that were lost during those times, but or it's definitely not equitable in terms of that. But some of these populations, and I can't say that they did better per se, but you could still see that the majority of these populations are still oppressed. Race of itself is a social construct rooted in history with the intention of maintaining control and dominance over social classes. They used to use science to kind of affirm the permanence of race, reinforce racial superiority, and justify differential treatment of people with phenotypical or phenotypic dissimilarities. Dr. Collins, who was the former director of the National Human Genome Project, in his studies affirmed that humans are 99.9% the same at their base genomic level, making us all one race. So if you look at the person in the box next to you, that we are all the same. There's that 0.01 percent that makes up like the differences on our hair, our skin color, our different eyes, and things like that. That make up our differences, but at the same time, that's not enough to constitute a different race biologically. So rather than focusing on preventing these social conditions that lead to racial disparities, society with historic backing of science has continued to focus on the disparate outcomes that result from them. Now, not to say that we haven't made some progress, right? Which I'll discuss a little bit more going forward. With certain government programs and things like that, some health outcomes have improved. Access to medical care has improved. So even though racial equality and equity is still going on, the evidence is to support the continued negative impact of racism on health and well-being through implicit and explicit biases. Institutional structures and interpersonal relationships remain evident. As medical professionals, failure to address racism continues to undermine the health equity for the increasingly diverse population of children, adolescents, and emerging adults and their families. Racism, okay, so now we're going to go into talk about the impact of racism of itself. As a core social determinant of health, it is a driver of health inequities. These inequities are not the result of individual behavioral choices or genetic predisposition, but caused by economic, political, and social conditions, as we had mentioned earlier. In terms of children, the impact of racism has been linked to mental health problems in children and adolescents. According to the Journal of Child and Adolescent Psychology, it has been related to self-reported internalizing symptoms of lower self-concept and higher levels of hopelessness, leading to increased numbers of depression, anxiety, suicidality as well. There's also a biological component that's related to chronic stress, which leads to increased and prolonged levels of stress hormones and oxidative stress. When we're continually exposed to hormones like cortisol, this leads to inflammatory reactions that predispose individuals to chronic diseases. And this has been an ongoing issue in terms of racial disparities, in terms of infant mortality and complications with low birth weight. This has been associated with discrimination and maternal stress. Okay. You could see here, I mean, this is within the last 10 years, and you can see the mortality rate between Black and white infants is substantially higher amongst Blacks. You can also see the trends are the same with short gestation or low birth weight, congenital malformations, maternal complications, sudden infant death syndrome, and all other causes are disproportionate. Okay. So as I was mentioning before, it's not that improvements haven't been made, right? There have been investments in policies to address social determinants of health, such as poverty. The food stamp program that started in the 1930s and then revised in the 60s has improved birth outcomes. Initiatives in education, housing, and access to health insurance has also improved health outcomes, especially in the realm which we deal with a lot in terms of pediatrics, in terms of lead poisoning, injuries, asthma, cancer, neurotoxicity, cardiovascular disease, and mental health. Expansion of health insurance has also improved access to the well child care visit, which I do every day, and doctor and dental visits, particularly in Black and Hispanic populations. So you can see here with some of these trends. In A, you can see that the uninsured trend has been going down. It's still lowest amongst it's still lowest in Black Americans. In B, in terms of in terms of poverty, you can see that there's still the most uninsured population, which hasn't changed much, but the near poor and the not poor has I'm sorry, reverse that. The poor and the near poor have been going down, but the not poor is basically the same. So as you can see with all of these, with different levels of access, it has things have been improving. And this is a similar slide regarding child health visits, dental visits, and such. So despite these improvements, it is still important to recognize that children raised in Black, Hispanic, and Native American households continue to face higher risks of parental unemployment. We're going to go into this a little bit more. Living in families with significantly lower household net wealth relative to white children in the United States poses barriers to equal opportunities and services that optimize health and vocational outcomes. So this is median wealth, and this is a survey from 2016. Okay. And you can see where Blacks, Hispanics, and other minorities fare in terms of mean net worth and median net worth as well. And this is based on change. The change in median net worth by race and ethnicity. Okay. All right. I also want to discuss a little bit about juvenile justice, because it is also an important social determinant of health. We have been seeing over time that the overall rates of youth incarceration have decreased, but Black, Hispanic, and Native Americans are still incredibly represented or disproportionately represented in this demographic. Youth arrests and delinquent behaviors have also been related to low socioeconomic status, family disruption, living in households with one biological parent, less residential stability, poor neighborhoods, and educational failure. Overall poverty is likely to be the underlying factor that most influences trends in juvenile crime. So when we go back and we look at this, then we can see that there's a correlation between wealth and this structure of juvenile crime. Socioeconomic status plays a significant role in Black and Hispanic youth, as they are more likely to live in poverty than their white counterparts. Was there a question?
Oh, no, I'm sorry. I hit the button. Continue.
Oh, good. Unemployment and underemployment is directly correlated with educational failure as well, which we're going to go into. Okay. I want to talk about children a little bit. So children can phenotypically differentiate race during infancy. So it's very important to foster ideas of um, that being different or as especially as a minority is okay, that it's normal, because this of itself can help develop a positive racial identity. Um, this helps mediate experiences of discrimination, doesn't lead to some of those negative, internalizing negative self-hatred kind of ideals. Um, if you have this positive racial identity, um, it also produces optimal youth development outcomes as well. Okay, so it's important to understand as healthcare providers, and honestly, really in the population in general, um, that racism occurs typically on multiple levels, 3 levels specifically. So institutional or structural, there's personally mediated and internalized racism. Uh, Children experience racism through where they live, where they learn, what they have, which are all of these are social determinants of health, um, and the rights that they're provided, essentially. Implicit and explicitly implicit and explicit personally mediated racism, which is racism characterized by assumptions about the abilities, motives, and intents of others based on race, affects healthcare delivery and general health outcomes. Subsequently, structural and personal mediated, the first two contribute to internalized racism, which is where a person adopts racial stereotypes about their racial group. So children may also experience personally mediated racism early in their schooling, um, which may be internalized and affect their interactions with others. Um, Student-teacher racial mismatch can impact academic performance, which affects, again, one of the social determinants of health. Um, Studies show that African American children are more likely to receive worse assessment of their behavior when they have a non-Hispanic white teacher than when they have an African American teacher. African American students who have one African American teacher in elementary school are more likely to graduate from high school and enroll in college than their peers who do not have an African American teacher. And this goes back to that student-teacher racial mismatch. Also speaks to, well, we're gonna actually talk about that in the next couple of slides. Where was I? Okay. These findings indicate the importance of ensuring a diverse teacher workforce, particularly as the population of students in the US continually diversify. This also speaks to how children are, how they perceive school and the disproportionate number of African American children who receive more than one out of school suspension in preschool and in kindergarten through 12th grade are suspended 3 times more and expelled 1.9 times more than white students. as pediatricians and, as other healthcare professionals, educational and vocational attainment are key outcomes to assessing successful growth and development. Um, Adults with a college degree live longer and have lower rates of chronic disease than those who do not graduate from college. This leads to the conversation of chronic absenteeism. Um, this affects graduation rates. Any student who is chronically absent for any year between 8th and 12th grade is 7 times more likely to drop out. Chronic absenteeism is defined as missing more than or equal to 10% of school days in an academic year, which is a strong predictor of educational achievement. It disproportionately affects children of color, children living in poverty, and children with disabilities and chronic diseases. In high school, 21.2% of Hispanic, 23.4% of African American, and 27.5% of American Indian children were chronically absent between 2013 and 2014, compared to 17.3% of white children. Children chronically absent from school for a wide variety of issues directly related to their physical, mental, and social health. And we have some examples here how these are affecting. So in pediatrics, we deal with a lot of asthma as well, which is for the most part pretty manageable. But if there's decreased access to healthcare, let's say you with a copay or something like that, if you don't have the money to afford an inhaler, you're gonna miss school. You're gonna potentially go to the ER for your treatments, and you're gonna miss school. And again, this does not lead to good health outcomes as children are growing. Also, mental health, fear, depression, social anxiety, and other mental health issues can make it difficult for children to feel comfortable when going to school. This also leads into issues with racism as well. Or if the child is not comfortable going to school, they're not going to want to go. It can also trigger mental health issues that can cause them to be chronically absent from school. Students who fear or experience violence or bullying are at increased risk for being chronically absent. In 2015, a report said that nearly 35% of Black students and more than 28% of Hispanic students were involved in a physical fight the previous year, compared with about 20% of white students. 20% of high school students said that they had been bullied in the past year as well. Social factors, food insecurity or hunger, unstable housing arrangements, unreliable transportation, job loss within the family, and lack of health insurance also contribute to chronic absenteeism. Are you guys starting to see how these trends are all tying together?
Absolutely. Yes, yes, definitely.
This is just a graph about chronic absenteeism. You can see that Blacks are 16.4%, Hispanics are 13.3%, American Indian and Pacific Islander are at the highest, but the lowest is Asian, and then second to that is white.
Now, are all these numbers consistent with living in poverty? So this is the entire group that lives in poverty, and this is their rates of absenteeism. Is that correct?
Correct. It's actually multifactorial, but yes, poverty is a big issue with the social determinant of health. So,
Have about 15 minutes.
okay, thank you. Okay. So, according to the National Center of Educational Statistics, the graduation rate for white students nationally is in 2015 to 2016 was 88%, compared with 76% of African Americans and 72% of American Indians, and 79% of Hispanic students. Disparities in chronic absenteeism and high school graduation rates prevent children from realizing the full benefits of educational attainment and can increase the development of chronic disease and reduce overall life expectancy. I do have a video that's about 3 minutes long. Can we do that?
Yes, please. Yeah.
Okay. Can you guys still see?
No, we can't see the video.
Some Americans are healthier than others. But did you know
You
that
have to stop sharing your screen.
how long
Okay,
and
hold on.
how
Go
well
to the website where your video is. Make sure on the bottom right-hand side, you select share audio sound. Stop sharing your screen first.
Nope, I don't want to do that. There it is. Okay. Stop share.
Now go ahead and share again. Select the website where your video is. Go to the bottom right-hand corner and say share computer sound.
Okay, got it.
We can see it now.
that's even more true today than
Can you hear
it has
it?
ever been.
Yes, we
Yeah.
can.
The last few decades, the life
Let me run
expectancy
it back.
gap between it comes as no surprise that some Americans are healthier than others. Did you know that your years of education can predict how long and how well you will live? That's even more true today than it has ever been. Over the last few decades, the life expectancy gap between more educated and less educated Americans has widened. Things are changing. Education matters to health more than it did in the past. And this is true, not just for how long we live, but how healthy we live. Disease rates are linked to education. Americans who don't stay in school, now more than ever before, are more likely to have obesity, diabetes, heart conditions, and other diseases. Health disparities disproportionately impact minorities and the poor. But differences in life expectancy by education affect everyone. In fact, although most Americans have enjoyed increases in life expectancy for more than a century, an alarming trend has recently emerged. Life expectancy has actually been decreasing for certain groups with less education. As an example, white women without a high school diploma are now living shorter lives than they did in 1990. There are many reasons that education matters so greatly to health. More education leads to better paying jobs, with benefits like health insurance. But that alone doesn't explain the connection between education and better health. More education and higher earnings means better access to healthy food and safer homes. It means neighborhoods with good schools, near jobs and transportation, all linked to health. In addition, children who grow up in struggling, stressful homes or neighborhoods pay a double price. The living conditions disturb their education, but the stress can also cause them to take up unhealthy or risky behaviors, such as smoking or violence, which can affect their health for a lifetime. Not only is education affecting our health, it's also affecting our economy and ability to compete globally. Today's high earning jobs require a more educated workforce. Consider this: 60% of new jobs in the 21st century will require skills that only 20% of the workforce has, according to the Department of Education. The bottom line is that education matters more now than ever. As policymakers struggle to balance budgets in challenging fiscal times, education funding is often the first to get cut. At the VCU Center on Society and Health, our research is designed to help policymakers and stakeholders connect the dots between community conditions, including where we live, learn, work, and play, and our health. Learn more about our research at societyhealth.vcu.edu.
Okay, so you guys get the point there. Doo-doo. Sorry guys, my dog. Okay, stop. Okay. Now we're back on the PowerPoint, yeah?
Yes.
Okay, perfect. Okay, so how can we address the problem? Okay, and it's a very long list of things. So I only really gave a couple of examples, but we can start by optimizing our clinical practices. We can try to create a culturally sensitive, safe medical home. This ultimately will require training for not only the office staff, but the clinical staff as well, to be culturally competent. We have to talk to our patients and assess their stressors, their day to day. As a pediatrician, it's one of our questions that we do ask about bullying, cyberbullying, and this based on race as well. We want to do a deeper dive and ask about some of these social determinants of health, and focus more on racism. Do you feel safe in your neighborhood? Do you where do you live? Here in Philadelphia, we have a large African American community, and that live in poverty. So access to even being able to come to the office can be an issue. So we need to do a better job of identifying those barriers. We can advocate more for our pediatric training programs, starting basically what we're doing now. We start at the level of high school student, and then you work your way up to college and med school and residency. So by the time you're practicing, you're already well equipped and well versed in addressing some of these issues. You want to be able to encourage policies to foster interactive learning communities that promote cultural humility and provide simulation opportunities. So, like sit down with as residents and go through with your attendings. Okay, this person comes in. How do I address this conversation? And it can be a difficult conversation to be had, but at the same time, it's necessary. You want to continue to advocate for policies and programs that diversify the pediatric workforce. More inclusion in our residency programs, med schools, colleges, offices, and where we work. You want to push for more diversity. And it can't just be in the office, but also reach out to the community, engage community leaders, because honestly, it takes a village to get some of these initiatives going. Because again, they are difficult, but it's necessary work. Acknowledge that health equity is unachievable unless racism is addressed. And again, you need interdisciplinary partnership with other organizations that have experience with that kind of work. And then from the research side, these are just some examples of things that can be looked at going forward, looking at the impact of perceived and observed experiences of discrimination on child and family health outcomes, the role of identification versus perceived race on health access and status and outcomes, and so on. Okay. How much more time do I have?
So you have about 3 minutes left and then about 15 minutes of questions afterward.
Okay. Well, I'm right at the conclusion. So this was said by Dr. Joseph Wright, who's on the board for the AAP. The AAP is the American Academy of Pediatrics. And it says the AAP holds that racism harms everyone, including children of all races and ethnicities. It is not a conversation that can be avoided. These are conversations African-American families have had to have for generations. But if this is not something for other families have discussed yet, what is happening right now is an essential and unavoidable teachable moment. If we are to progress in this country, it's going to be because we help our children, adolescents, and young adults learn not just that racism exists, but that it is something all of us can work on together to dismantle. Racism is inexorable. And that's from Dr. Wright. Okay. And that's it, guys.
Well, that was absolutely wonderful. Thank you so much. I would like to open the floor to any questions. I have about 2 questions, but if anyone else wants to go before me, please go ahead. Otherwise, I'll start my questions. It's okay to leave a question in the chat and I can read it for you if you want, or, feel free to pipe up.
I do have a question. Dr. Howard, you mentioned that that 0.01% isn't enough isn't enough to create a whole new race, right? I was wondering if there was a percentage that would be like, is that a thing or?
To constitute a new race?
Mhm.
That I am not sure of that specifically from but as human beings, all right. So as you and I and the person next to you, we are 99.9% the same. You know. So if you look at, let's say, like two panthers, right? Like one is like spotted and the other one is completely black. You don't necessarily, you might call them different things, but they're of the same species, they're of the same race, right? So just because they might have subtle differences doesn't make them any different. See what I mean? But I would implore you also to look into the Human Genome Project as well, um, uh, to see if there's anything that would constitute that. But I haven't come across that.
Great question. So, I have a few questions. So, you spoke a lot about how representation in the teaching environment really helps minority students of color. I've actually heard people who are maybe a little bit less knowledgeable about that area in particular use that as an excuse to say separate is equal, right? Since, minority students do better when they see people who are like them in environments, and when really it's an excuse for diversification, right? Because as long as someone's culturally competent, it really doesn't matter what race you are, right? But the problem is that we don't live in a society that demands cultural competency. So, how would you sort of fight against that rhetoric based on the literature that you just showed us that says, like, maybe, black students or Latinx students should go to an only Latino or only black school or something along those lines, versus someone who says, no, we need more cultural inclusion in our learning spaces.
Right. I completely agree with you. And people would use that literature divisively, and it's not, that's not what it's saying. And I would use, these statistics to say that exactly. Just to say it doesn't say, it's not exclusive, but we're talking about inclusivity. We're talking about a coalition of teachers that look differently, so that that way we can relate better to our students. And not only are we not only are they learning from us, but we can learn from them as well. And that's how I would address the conversation. Because this, especially in within the context of race, I would say that this part of the problem is that people can't, they want to have this whole separate but equal mindset. Well, you guys deal with it over here, but it's everybody's issue. And it's something that everybody needs to work on versus just just each race. So
Absolutely. It says Samir Hampton raised his hand. Do you have a question?
Yeah. Hi. Can you talk more about the cortisol levels in relation to mental health and how that's like manifested in like the body of a person?
Well, the cortisol levels, cortisol's released by from ACTH, and the pituitary goes to the to your adrenal glands, and then you release cortisol. This of itself is a stress hormone. So and causes inflammation in the body. It's not necessarily, it's more related to like let's say your fight or flight. Like if you're more stressed out, you're going to release more cortisol in your body to help foster and catecholamines as well, right? So you're going to increase your heart rate, and everything gets triggered along those lines. But cortisol will get released as well. So if you're in a state of constant stress, this will perseverate the body to be in a constant state of inflammation, and this of itself leads to more medical problems.
Wonderful. I have another question. So, COVID-19 was a mess. And as we already know, like 2020, beginning of 2020, just hot mess. But, we're sort of turning around the corner a little bit. But as we know, COVID-19 affected, Black, Latinx, people of color more than it did our white counterparts. And in addition, closing of schools actually hurt, African American, Latinx, because majority of those folk have service industry jobs. And despite school happening online, they couldn't really be active participants in that because they still had to go to work during the height of the COVID-19 issue. Did you see any significant ramifications in children during that process? And can you sort of describe that, if that's okay?
Yeah, absolutely. Absolutely. We see it a lot, actually. So we always, so in the office, we, for our kiddos who are, well, our young adults that are 12 and up, everyone gets a PHQ-9, which is just a depression screening. And we've seen over this year much higher numbers than we were seeing before. And some kids, with a lot of anxiety, kids who've never experienced any mental illness in the past. Over this last year, we've seen increased rates of panic attack, panic disorder, depression. I had one young lady who was 13, whose PHQ-9 was 23, which is incredibly high. And she had never had any history of depression or suicidality, anything like that. So we have been seeing more of that, which is, to have those wraparound services for psychology available was very helpful. But also the problem was not so much of a problem, but we were doing more counseling in the office as well than we had before because of necessity. A lot of the counseling groups that we would refer to, or counselors that we would refer to, were overbooked. So we would have to, so we're talking about a couple months out, and I'm like, this kid, needs to see somebody or at least talk to somebody soon. So we would bring them back a month, 2 weeks, 1 week, whatever was really necessary. But that definitely ramped up over this last year. So,
I really appreciate that question. And I appreciate you answering that and giving us those stats in regards to how much it increased. And I look at that, I'm listening to you talk, and the first thing I think about is, well, what's happening with our medical students? What's happening with our graduate students? What's happening with employees, right? What's happening with everyone? We are all being traumatized by the events that are happening. And if you're seeing an increase in children, can you imagine what it is for everyone? And the need for us to be able to do wellness programs, for us to have a wellness counselor, a psychiatrist, a psychologist, and really tap into that. I think we're looking for a director now for wellness, which I'm so excited and can't wait for the person to get here, because it's going to have long ramifications. right? It's not going to just be, okay, now we can go back outside without our mask on. It's like some people scared to go outside still without their mask, and they're still experiencing some of the trauma that we have experienced over the last year, and that continues, especially when we talk about the Black Lives Matter movement and all the injustices that have unearthed in that. We've been dealing with that for many years, and it's woken America up, and now the pandemic. So, yes, we definitely have to do some things differently. And this was a great presentation, and I appreciate you taking the time to share your skills, knowledge, talents, and abilities with us and your expertise. So thank you for that. But I also want people to keep it on the radar. Although you are talking about pediatrics, we have to look at the entire community, right?
Absolutely. Absolutely.
Right. So there is one more question in here. I want to get to the closing first. So I'll do closing remarks first, and then we'll get to the rest of the questions for those who have time, if that's okay. So let's just do the closing remarks really quickly, and then we can get to the rest of these questions. Let me pull up the
And Jason has his hand up as well. So after we're done.
wonderful. I just don't want to, these are such great questions and it's a great conversation. So I don't want to lose that. So let me try to we'll share my screen and get it done like this. I can, well, can you see that?
Yes.
Okay. So closing remarks are going to be done by Jennifer, who's an MBS student, class of 2021. Jennifer, do you want to take it over?
Yes, thank you. So my name is Jennifer Fashon, and I am an MBS student at Guy Sanger Commonwealth School of Medicine. Thank you so much, Dr. Nicholas Howard, for your presentation. It was definitely very informative. And please join us next Tuesday, June 29th at 12 p.m. as we welcome Dr. Cy R. Wilkson from Memorial Sloan Kettering Center as he speaks on cancer in Black men, the disparities, and the sciences. So also watch episode 4, Control, as part of Netflix Amend, The Fight for America, ahead of discussion today from 5 to 6 p.m. Thank you guys so much for joining us.
Thank you so much. I'm going to stop my screen share and let's get back to some of these questions since we have. So I know someone put their hand up, but I believe this was first. So this is, so sorry if I get your name wrong, but I want to say Jaeger. Is that Jaeger Kabikishi? Keisha? Something along those lines. Please correct me. It is okay. Your name is important. So if I'm saying it wrong, please correct me. But speaking of mental health, do you think African Americans are more likely to be misdiagnosed when it comes to mental illness?
Very good question. Honestly, I think they're more likely to be underdiagnosed than misdiagnosed necessarily. In practice, I have come across families that say, "Oh well, no, they're fine. They don't have any mental illness." But again, that same PHQ-9 is high. It's anywhere from 10 to 14 range, or even mildly elevated. And it's something that I always address with my patients, at least to just go over the questioning and everything like that. But some of them legitimately are depressed, or they have suicidality or something like that. And a lot of times parents will say, no, no, we're not like that. And because the issue is, I think they're afraid of the label. And oh well, they're gonna see this, my child is Black already, and it's gonna make things worse for them. So they, a lot of times I think that it's underdiagnosed. A lot of families won't bring it up at all. It's usually, so when I speak to one of my adolescent patients, I always start with the parent and the child. Then I'll have a conversation, ask the parent to leave, so I can have a conversation with the adolescent, so they can speak openly. I let them know that everything that we discuss is confidential, and we, you know, unless they're going to hurt themselves or somebody else, at that point, you know, it's a medical emergency. But beyond that, I try to give them an opportunity to speak openly. And a lot of the times they do, and they're very cavalier in terms of their feelings. And then I have to go back and have a conversation with the parent, and then try to inform them that there's nothing wrong with, it's just another part of health. You know, mental health is just as important as physical health. And, you know, and just like that, it needs care. So.
Wonderful. And I believe, Jason, you have your hand up. You'd like to ask a question. So go forward, my friend.
Thank you. Thank you, Dr. Howard, for your presentation and all the information you gave me. I do have two questions. Before I get into the questions, like about 3 or 4 days ago, I had written down about 3 names in one of my notepads, and I'm interested in pediatrics, and I wanted to, you know, reach out to one of these doctors, and it just so happened to be that the one of the 3 was you. So just getting to hear you and, you know, understand your story and just understand the information that you're putting out and expressing to us, it was actually a really great time for me. It was really a blessing, and I really do appreciate that. But my first question was, when it comes to you and your patients, and you know, you have your African-American patients or your minority patients in general, how do you feel like you switch it up in terms of making sure your relationship with them is like very, I would say, I guess, like interconnected, you know, in a way where you can feel them and they can understand you, and it's not like a bridge or a gap? That's my one question. And my second question was, I didn't know how busy you were, if you were open to any type of shadowing or anything like that. I would love to reach out and build a deeper connection, but you know, you let me know.
Well,
Absolutely. You better ask that question, Jason. I love it. You go for what you want. This is wonderful. I'm sorry. Go ahead, Dr. Howard.
No, you're good. You're good. You're good. I applaud that also, my friend. And yes, this is a big part of why, like in our practice, we have 6 offices, right? So I work in Northeast Philly and North Philly, right? Because of the demographics there, right? So Northeast Philly is a melting pot of people, right? I would say about so I get Hispanic, I get Brazilian, I get all different countries in Africa, in terms of my patient population. So I love it, because again, I'm very interested in global health as well. In the other office that I asked to work at is in Elkins Park, right, which is on Cheltenham Avenue. I would say probably 90% of my patients there are African American or Black. So to answer your question, I would love for you to come out and shadow, and we could talk about peds and, you know, push that forward, man, because we need more, right? And to how we stay interconnected, honestly, a lot of times the parents and the patients know before I even say anything. You know, they're happy to see a provider that looks like them, and at the same time, I'll just be very real with you. I keep it absolutely 100 with my patients. Like I tell them, I don't sugarcoat based on whoever it is. If there's something going on, I let them know. You know what I mean? But I tell them where I'm from, and I don't shy away from that. I'm 100% myself. You know. So, and I think a lot of times they feel that and they appreciate that. You know. So I just, you know, you don't. Because well, I don't know. There's a whole other conversation about code switching and things like that too, right?
Ooh, open the door. Yeah. That's a real thing. So
It's a real thing, you know, and while you're in school and you have this education and you're learning all these things and you know, like I said in the talk, education is a powerful tool, you know, and it'll afford you a lot of doors to be open, right? So you have a lot of different experiences with different people, and then you learn how to interact with everybody, right? But you cannot forget where you came from. You can't forget about who you are as a person, but at the same time, you know, you apply what you learned to, you know, your people, essentially. So I didn't know a better way to say it. So that's.
oh, wonderful. All right. Well, currently I have a patient waiting on me, so I gotta go. But I will leave the floor open for sure if you guys want to continue this conversation. But otherwise, I'll be tapping out. This was wonderful, and I can't say enough how thankful we were for you to, you know, take time out of your busy schedule to come and speak to our organization. We appreciate you. And I'll be potentially hitting you up for another opportunity if that's all right. We enjoyed our time with you today.
That's perfectly fine, Dara. Thank you so much for everything.
Absolutely.
And take care of that voice, man.
Let me tell you, I'm trying. Right now I'm on my Anita Baker teas. We'll see what I come back as. We'll see how it bounces back, you know, on Barry White moments right now.
Well, I know Dr. Howard has another appointment as well. I do too. I'm doing a training for the Detroit Health Department, their first part of my 3-part series. So I got to get ready for Detroit Health Department. But thank you all so much for coming. Please, like Jennifer said, check us out at 5 o'clock. We're going to talk about the Amend video. If you have Netflix, please watch it before coming at 5 p.m. this evening. And we're going to talk about that and have more dialogue. Jennifer, we're on episode 4, right?
Yes, episode 4.
Next week is 5, and the July 6th is 6. It's going to close us out. And we have Dr. Wilkins next week, and he's going to be the last one in the series. So all of you, please come. Dr. Howard, thank you so much. Enjoy the rest of your week. Get me your paperwork so you can get paid. And we are done. Take care, everyone. And thank you so much for coming. I really appreciate it. And I don't know if you got a chance to look in the chat box, Dr. Howard. You have a number of thank yous and appreciating you for your session. So you all take care.
I appreciate y'all. Thank you so much. Keep up the good work. Stay strong, guys.
Absolutely.
Thank you.
Thank you.